Thank you again for coming to the President's invited session on waking up the public to telling our stories. And I really am honored to be the president of ACC this year. I appreciate the chance to serve. And one of the opportunities that the president gets is to put together an invited session at the annual meeting. And this is it, and I appreciate all of you attending. So this is me. I happen to have a day job besides being president of this association. I work at the Emory University here in Atlanta, and I'm stationed most of the time at Grady Hospital, which is about 2 miles away from where we are. And if you're interested, you just take a walk over there and take a look. You can't miss it. It's a 950-bed hospital, and I'm pleased to serve there. I do have some disclosures. We should probably let you know about that, although I don't think any of these will pertain to today's talk, except maybe AACC. I'm biased towards AACC, as you would have guessed. All right, what is the value of clinical laboratory testing? What do we need to articulate to people in general? Clinical laboratory testing is objective. What else in medicine is objective? There isn't very much, frankly. Most of it is subjective or biased. You talk about a bias, a conflict. It's very difficult to avoid that in handling patients, taking care, making decisions, except for the laboratory. The laboratory and maybe radiology provides objective evidence that can be used to make good decisions. It's quantitative. This is the digital age. People get quantitative data. They understand numbers. So the laboratory largely provides quantitative data, and this is a good thing. We need to be able to articulate that. And we are a source of evidence. This is evidence-based medicine era, and people like to have evidence. And the laboratory provides a source of that evidence. And it's personalized. There's a lot of things going on, a lot of discussion about how do we know which patients are going to respond, which patient needs this drug versus that drug. And the laboratory and the data that we provide can do that. And we also are relatively inexpensive. I could spend the next 2 hours, we don't have time for that, talking to you about the cost of the laboratory versus the value, but it's largely inexpensive. And it's responsible for influencing many of all the decisions that are made by the physicians who are trying to take care of us as patients. But I have some concerns about laboratory testing, which is why this is my presidential symposium and why it's one of my platforms this year as president. Clinical laboratory testing is undervalued by the society and other healthcare professionals. So we have a problem, and that creates over-scrutiny for cost reductions by payers and government, and people are willing to reimburse for the work that we do. And I just heard more about that this morning at the International Market Briefing, which is about 400 people that are interested in marketing laboratory tests, but they can't really market them. They can't get forward on that if they're not going to have any reimbursement. So these issues of us being undervalued influence the reimbursement decisions. And we have a great profession. We are friendly people. We're engaged. We enjoy doing what we're doing, but we have a disturbing lack of visibility. And then, therefore, we're an afterthought by our healthcare organizations that we work for and by society at large. So my goal for 2015, and frankly beyond this year, I'm not going to give up on this, is to see us to be able to promote the importance of clinical lab testing to the general public, number one. And then when we get that across, maybe we can get our clinical colleagues to agree. We have several people already, and one is in the room here who understands this very well, but not enough of them do understand that. And we got to get it across to the government and to our policymakers and the people making reimbursement decisions, and we've got to get it across to the media. And we're doing more of that all the time with AACC. You heard me mention that a little bit yesterday, those of you that were at the opening plenary, but we need to do a better job at that. So the plan for my invited session is this. We're first going to hear from an expert in telling stories. How do we get this job done about telling our stories? Maybe we've not done it very effectively in the past, and so Lori will help us with that. Then we've got Dr. Alan Wu. You think you all know Alan. He's a clinical chemist, been very active in a number of ways in our association and in the profession. But I've found that Alan and I have a lot of commonality in this goal, in this thrust. And so we hit it off on several occasions, and then Alan led me to say, well, let's combine efforts. And so, frankly, I owe Alan a lot of credit here for getting this all put together. And Alan will give us some storytelling examples. And then Alan introduced me to John. John is from Australia, and they've been doing some interesting things there in Australia in this regard. And so John will tell us the story there. And then I was fortunate enough to meet Dr. Bruce Ribner from Emory, and he will finish up today and tell us the story about taking care of Ebola patients and how the laboratory really made a profound difference in the care and the success of the treatment of those patients. So without further ado, we're going to have Lori get started, and Lori is all mic'd up and ready to go as soon as I introduce her. Lori is considered a thought leader in the field of business storytelling, and let me add science storytelling to that because that's the thrust here today. Lori has written several books, including the bestsellers Wake Me Up When the Data Is Over and Business Storytelling for Dummies. And Lori will be at the ACC bookstore tomorrow from 1 to 2 to sign some of her books. So please put that in your schedule if you're able to go. Avail yourself of that opportunity. Lori, for more than 25 years as the owner of Partners for Progress, a management consulting firm, and she's also helped organizations craft innovative long-term strategies and implement large, many changes. So please welcome Lori Silverman.
Thank you. Thank you. The clock was ticking. As director of the Utah Public Health Laboratory, Robin Atkinson had exactly 13 calendar days to put together a brand new budget proposal. She had just finished a meeting with her boss where they'd been discussing an ongoing issue. You know, how do you get new technologies into the molecular testing section? And the challenge was always the same. How do you do that in an area that's federally funded? But this time, her boss had an idea. Robin, here's what I'm thinking. You know, I think it's time for you to go for state funds. And there's a building block that's available, and you've got all the justification. So maybe what you need to do on August 20th is tell the powers that be that giving money for molecular testing technology is a great use of taxpayer funds and will help to protect the public in Utah. And you know, on that day, the deputy director and the executive director of the health department are going to be meeting and listening to proposals. And then they'll be taking whatever proposals they think are worthy to the governor's office. So if you choose to do this, just keep in mind you only have 15 minutes to get your point across. The next day, Robin learned who she'd be going up against. Folks asking for money for maternal care, for child care, for obesity, for special needs kids. You know, those other issues are pretty easy to understand. But, you know, our work is so complicated and so complex. I mean, how am I going to get them to understand it? I know what I'll do. I'll talk about the history of the lab, give them some context, and then maybe I'll talk about some of the nitty-gritties that go with it, like the sort of testing that we do and who we serve, and then I'll lobby for the money. Being the good laboratorian that she is, she put together a very, very detailed handout that was a business case. And on top of that, she also prepared a very detailed PowerPoint presentation that outlined the who, what, where, when, and how of all this was going to work. But what she also knew was if you move people at their heart, that's a way to influence. So she thought to herself, well, maybe what I need to do is fabricate a story. I'll fabricate a story about a young girl who's like a year old whose name is Bonnie. And in that story, I think what I'm going to do is I'm going to stress how Bonnie could have been treated sooner and not died if molecular testing had been available. You know, in her science mind, it all made great sense, right? How could you not be protecting the citizens of Utah if you were able to diagnose and treat patients sooner and give them what they needed? But just to make sure, the Friday before the Monday presentation, she sent her talk out to her boss and all of her colleagues, begging for feedback. Her boss was first to respond. "Great job, Robin. I'm certain you'll do well." Jeff followed, Now, he's the head of development and process improvement. He's the guy who helped her to put together the business case handout. And Robin couldn't help but smile when she read his email. He said, "You rock. Go for it." But just to make certain she had everything polished perfectly, she told the presentation to her new husband over and over and over again all weekend long. Now, before you know it, it was Monday, August 20th. And it was a scorcher of a day in Utah. It had been 90 degrees Fahrenheit for more than a month. So Robin, over her boot cast, which hid her broken foot, put on a maroon-colored sheath dress, and because she knew the air conditioning would be on, she put on a little tiny black sweater and some earrings that she had gotten from Mexico. And then she went off to work. 90 minutes before Robin and her colleagues were to do their presentations, her boss decided they should do a run-through. And Robin got great feedback. "You're going to do so well. We're cheering for you." Before you knew it, it was 3 o'clock. And wouldn't you know it, Robin was sandwiched right between the request for special needs kids and the one on obesity. But when it was her time to speak, she stood up in front of the executive director, who was to her left, and the deputy director to her right. Now, the executive director, well, he was a guy in like his late 50s, kind of portly, graying hair, big bushy gray eyebrows. And the other gentleman looked quite the opposite, even though he was of the same age. He was very tall, slender, athletic build, and mostly balding. Now, behind her, there were 12 people who were listening into the conversation to see how it went. And Robin did exactly as she had planned. She went through all the preliminary information to set the context, and then she started to tell them the story about Bonnie, the 1-year-old who had passed away from pertussis. And before you knew it, the conversation took an unexpected turn. "Robin, if we're hearing you correctly, pertussis seems to be a very serious health problem. And if it's such a serious health problem, don't you think we should be looking at vaccination schedules? And I know you're here to get monies for new technologies, but maybe what we ought to be talking about is the cost of those pertussis kits." As Robin was listening to their words, she couldn't help thinking to herself, no. We're not here to talk about pertussis. We're here to talk about molecular testing technology. What's going on? Stop. 25 minutes into her 15-minute presentation, she finally got them back on track. When again, before you know it, they took off in a different direction, and they started to give her pointers on how to improve her presentation. By that time, Robin knew she had lost them. That day, she went home very deflated. And a couple days later, she got that email that said, "Try again next year. We're not taking your request forward to the governor's office." Now, I met Robin after this situation had happened. She was about to attend a week-long training session that I was doing on lobbying and how to incorporate storytelling into lobbying, and then going to Capitol Hill and telling stories to congressional leaders. What Robin told me she knows all too well is, when you take and you fabricate a what-if story to make a point about a problem and what you kind of need, and then you go and you tell it from someone else's point of view, well, it can backfire on you. And so what she wanted to learn that week was, how do you pick and polish the perfect story? Pick and polish the perfect story. Now, let's roll ahead to 2015. Robin had the opportunity again to go ask for state funding, and she had taken the time to pick and polish the perfect story. This year, she got $300,000 in programmatic surplus funds dedicated to buying the new technologies that she's wanted. Now, what about you? How many of you in this audience have needed or wanted to influence people just like Robin did on that fateful day 2 years ago? And how many of you have had the situation gone awry, where you haven't gotten what you wanted? How many of you have tried to relay to other people the importance of clinical laboratory testing, and it's fallen on deaf ears, and people won't listen to you. Well, maybe we need to do what Robin learned, and that is maybe we need to learn to pick and polish the perfect story. You see, the perfect story, in a nutshell, has 4 pieces to it. First of all, you need to know what key point you want to get across to your audience. Why is that key point important? Because that key point is about what you want people to do differently after they hear your story. How do you want them to behave differently? How do you want them to think differently? How do you want them to feel differently after they hear it? And attached to that, you're going to put a call to action. Because, otherwise, without those 2 pieces, people just go, oh, that was a nice story. And they don't do anything different. Our job in bringing stories to people is to cause them to take action. Once you have that key point, then you go in search of a story that demonstrates it. Now, most people do it just in reverse. They go and they find the story, and then they hope that it makes the key point they want to make. It doesn't work that way. You have to go do your key point first, then go find the story that demonstrates that key point. Once you've got that story, you have another challenge, and this was Robin's challenge with Bonnie's story. You need to decide which perspective you're going to tell the story from. Now, let me step outside the situation for a moment and give you an everyday example. My friend Dave is an avid cyclist. In fact, he cycles in Phoenix, Arizona, about 30 to 40 miles a day. A year ago, he was hit by a car. Bike was totaled. He ended up in the hospital. Now, Dave could tell that story from his perspective. Or he could choose to tell it from the perspective of the motorist who hit him. Or he could choose to tell that story from the perspective of the passerby on the street corner who was watching the situation happen. Or he could choose to tell that situation from the perspective of the citizens group that's responsible for the neighborhood in which there are the bike lanes where he was hit. There is no right or wrong. But what you have to think about is, in order for your key point to stick and for people to take action, which of those perspectives is the one you need to take? And in Robin's situation, she should have told that story from her perspective, not from the perspective of Bonnie. And then there's one more piece to this. I have yet, in my 12 to 15 years of capturing other people's stories, as well as my own, what we call a raw story, have found one, well, maybe one, from a guy who's like an expert columnist at NPR, that was perfectly told to me. You need to craft and polish your stories, because here's what often happens. When people give me their raw story, they often give me the ending of the story before they give me the beginning of the story, and guess what? People tune out. That's what's happening a lot in the news media. That's called a news report. It's not a story. People say, why should I listen anymore? You already told me what the key point of the story was after the first 30 seconds. I don't need to listen. We need to do just the reverse on that. Second, we also need to be thinking about, do we have the elements that are critical for a story to be a story in the narrative that we're telling other people? Very often when people give me, when I capture their example, is they're giving me an example, or they're giving me a description, or they're giving me an anecdote, or they're giving me a case study, but they're not giving me a story. So my purpose in being here today is to talk to you about why story? I mean, why story over other forms of narrative? And second, a little bit about how to pick and polish those stories that you'll be using going forward. Now, when I was in college at the University of Wisconsin in Madison, my father paid for my room and board and education for the first couple years. And we got meal tickets. And the first thing that I would do at the beginning of the semester, and how many of you would join me in this, I would sell half my meal tickets so I could get cash, so I could do what? Go buy clothes, get makeup, right, get my hair done, other sorts of things. And then I'd find myself at the end of the semester with what? No meal tickets and being hungry. So I would have to find ways to make money. So we are all right now in this room students, just like I was. And Deborah Small is the professor, and we are in her study. Now, the study itself at the University of Pennsylvania is not important, But what is important is that each of us has been given an envelope. And in that envelope is a letter and 5 $1 bills. However, each of us has gotten a different letter. A third of us over here have gotten a letter that says, there's a little girl in an underdeveloped nation. She's going hungry. She has no clothes. She doesn't have a place to live. She's not going to get an education. And would you please donate? The middle group of us here got a different letter. That letter was about the organization who supports the millions of children like this little girl, the sorts of issues that they're facing in all sorts of underdeveloped nations, the statistics around what they've been able to do, and would you please donate? The other third of us over here have gotten a letter that's a combination of the first two letters. It tells us the story of the little girl, and it tells us the statistics, the data around the organization that serves children just like her. And would you please donate? Now, with a show of hands, I'd like you to tell me which group do you think gave the most money. How many of you think it was group number 1 with the story about the little girl? Show of hands. How many of you think it was group number 2 with the statistics, the data? How many of you think it was group number 3, the combination story and the data? Well, I'm here to tell you that hands down, it was group number 1. Now, here's the $64,000 question. This is the secret that guided Robin this time when she went to ask for her request. I'm going to ask you between groups 2 and group 3, which one do you think gave the second most amount of money? How many of you think it was group 2 with the data? How many of you think it was group 3 with the combined story and the data? Well, you see, I asked you a trick question. Because group number 1 gave this much amount of money, and groups number 2 and 3 were no different. They gave much, much less money. Now, you're probably sitting there thinking to yourself, how can that be? So we need to talk about a couple of things. First of all, how does the human brain work? When people say to you that the data that they heard went in one ear and out the other, they are actually correct. The brain has no capacity, other than through memorization, to remember data. None. None whatsoever. The brain craves sensory information. Visual, auditory, kinesthetic, taste, smell. And it loves it in the form of story. Because when it hears a story, it says, memory, memory, and it goes into our memory. And then when someone says a story prompt, like, tell me about a situation when, the brain goes, oop, I can recall that story immediately and tell it to you. Isn't that fascinating? The other piece is story is whole brain. Means it covers the conscious and the unconscious mind. That's critical. Because in covering the unconscious mind, that's where our decisions start to get formed. That's clear area. That's where we can get programmed. And story, that key point and call to action, can move people at a level they don't even understand. So when people say, I feel compelled to do something, and I don't know why, you've touched the unconscious mind. As soon as you pair data with that story, you negate that effect. And you shut down that unconscious mind, you turn people to logic, and they move to what? Debate. And my question to you is that the response you want? And I dare say it probably isn't if you're trying to influence someone, because you just want them to take the action that you know is important to take in a given situation. So what does that mean to the power of story? Stories touch us in 4 ways. First of all, they touch us physically. We now have research to show, if you can imagine, that the very parts of my brain that lit up as I told you the story about Robin are the very parts of your brain that light up simultaneous. That means there is almost this magical connection between me as a teller and you as a listener. There's some sort of bond that's formed between us that we don't even know. But on even a more physical level, If I were to connect you to medical equipment and study your heart rate and your breathing and other sorts of things, when you listen to a story, even one that has a lot of calamity associated with it, you tend to move more into a relaxation mode, which makes you more receptive to being influenced by someone else. In terms of the mental, I speak fast. I speak at 150 words a minute. Your brain works at 800. When you're listening to me, you have 3/4 of the time to daydream, except if I'm telling you a well-structured, compelling story. If I choose to tell you a well-structured, compelling story, I can take away some of that daydreaming time. Because you're thinking to yourself, well, I wonder when I was in a situation like that. Maybe I know Robin. Maybe I know someone who looks just like the executive director or the deputy director of the health department. Or I've gotten that response before. Or you're thinking about, geez, what would I have done if I were in her shoes? Or how did that work for her? How did she go from not getting what she wanted 2 years ago to getting what she wanted in 2015. We think about all the different issues surrounding relevancy. So I capture more of your mental space, and I keep you attending to my message versus all the other distractions that are around you. The third piece is, and this is where people think story stops, is the heart. And Robin was right about this piece. The best stories are those that take us through a variety of different emotions, highs and lows, and from laughter to tears. However, I believe in today's world that's not sufficient. The media hits us all the time with those sorts of messages, and I believe we've become pain tolerant. So it's not enough. It's necessary, but it's not sufficient. I really believe that the stories that deserve to be retold and the stories that will on their own get legs and be told all over are those that touch the human spirit. Now, I can't quite explain this other than I know these are the sorts of stories that, for me, when I hear them, make the hair stand up on the back of my arms. They give me goosebumps. They make me shiver. There's just something about them that is so powerful and so compelling. I can't wait to retell them to someone else. And that's what we, too, need to look for in terms of stories. Because there are some stories, quite frankly, that don't deserve to be retold. And there are some stories that we're not ready to tell yet, or other people aren't ready for us to tell. And we have to keep that in mind as well. But there's a third lesson that comes out of this research. And by the way, it was duplicated by other academics, other than Deborah Small. And that is, you need to learn how to storify data. I just did it when I told you about the research study. Did I use any numbers? Anybody hear any numbers? I just said highs and lows, and these two were the same, right? And I think you got the point of the story. We need to free our stories from the data. There are 3 things you need to do. These will sound simple on first blush. As I say them, I'm often reminded of when I was in an honors organic chemistry test, and I thought I knew everything cold for my exam, and then I got the results back, and I got a C. And I said, how could that be? Like, I thought I knew it, right? Because it seems so simple, but yet the work is really hard. The first thing you need to do is you need to sit with the data. I mean, literally just sit with it. And have it give you voice. Listen to it. What is it telling you? Are there patterns or themes or issues? Is there something dramatic in that data that needs to be called out? Because what you're seeking is what's the key point in the data? What's that one singular message that's really important for me to convey? Now, there might be some other messages as well that are secondary messages that are important. But you've got to figure out from that data what's that one message that's really key for you to convey to others. Then, just like before, you have to go in search of the story that will help to best portray that message. Now, when it comes to portraying problems or issues, real-life stories are often the best. When it comes to projecting a vision of a change as distinct from pain and urgency, then yes, you may have to fabricate a story, a dream story or a future story. And there are different ways to do that as well. The third thing that you need to do once you have those other 2 pieces is you have to think about how am I going to structure the story. Now, in the time that I have remaining with you this afternoon, I'm going to talk about the most basic of story structures. But when it comes to data, there's a lot of other opportunities that are available to you to structure a story to get your point across with that information without ever relaying numbers. Now, just as an aside, there are other more physical ways to separate the story from the data. It may be in my presentation that I present a story and my data is in a handout that I give to people. Or it could be, if I have an annual report, for example, that the story is in the beginning of the annual report and the data is in the appendix itself. Do not have them on the same page, and do not have them on facing pages, because they will still have that negating effect. You need to keep them separate from them. So you really do have to spend a lot of time looking at your data going, what's it saying to me? What's it telling me? What is the message that it's telling me that I need to relay to other people? And then what's the story that's going to help me to get those points across? Now, when I first heard Robin's story as I was preparing for this week-long workshop, I knew it was a story that I wanted to capture because it was important to the key point that I wanted to set for the beginning of the week, just like it was for our presentation here today. What I do when I go to capture stories is I don't ask people to write them out. I capture them on a tape recorder. I call them up. I have a little tape recorder from Walgreens that I spent maybe $10 for, and I tape it. And I don't say anything. I say to them, give me the longest version of the story, all the nitty-gritty details. Because you see, I can always make the story shorter, but I can never go back and get all the details later on. One time when I did that with someone, my transcript, when I transcribed the story afterwards, was 72 pages long. And my client needed me to get it down to the front and back of a sheet of paper, which I did. It's possible, but I had all this information that I had to kind of winnow and sift through. With Robin's story, I planned for about half an hour on the phone. I captured the story. When she was done telling it, then I said to her, what's the key point of that story for you? As distinct from the key point that is resident in the story itself. All stories have their own messages. The dilemma you have sometimes, and I had this happen with a client organization, was I captured a story, I figured out the key point, the person whose story it was confirmed with me that that was the key point, and the client said, I don't like that key point, change it. And I said, no, you don't understand. The key point goes with the story. It never changes. The call to action might change, but the key point of the story is housed with that story. So you can't just like modify it on the fly. You have to say, what's the message, the universal message that I want to get across to other people? And I asked that of Robin, and she said, know your audience. And I said, cool. I said, I'm going to switch that around for the purposes that we're using and tell me if this still fits with you. Is it still about picking and polishing the perfect story? She said, absolutely. Because I'm missing some of those pieces. Actually, I'm missing a lot of them because I thought I had the perfect story. I really didn't polish it. I didn't take the amount of time I needed to actually think about what perspective I was going to use. So yeah, I've learned that we need to do all of those different things. Then what I do with the transcript is I look at the information and I say, is it structured in this basic way? If not, I move pieces around. So if you know a normal distribution, you know the structure of basic story. There's the beginning of the story, there's the middle of the story, and there's the end of a story, and we're done. Okay? Kind of simple, right? The beginning of the story is the context. Like, who are the characters? Is temperature important? Is weather important? Are other characters involved in it? What's going on? Now, there is one thing we have learned from some research called compassion fatigue. People can only identify with singular characters. That means if you have a group of people who are a singular character, you have to give them a single name. So, for example, when I was doing a keynote talk for a conference for information and data quality professionals, there were 3 men who were the main characters. I called them the Band of Merry Men. Singular character. I didn't talk about them individually by name. And the Band of Merry Men did this, and this is what they said, and here's what's going on, because it was important to my audience. With compassion fatigue, what happens, even when you get to 2 characters or 3 characters, who are all primary characters, people stop listening. There's no empathy. They can't empathize with multiple people, but they can empathize with singular beings. That's why a dog on a cargo ship that got left on an iceberg outside of Finland or Iceland one day got more money donated to its rescue than children who were hungry in the United States in a single week. Kind of sad, isn't it? We can't deal with this mentality around how do we empathize with groups of people. So with that, we have the basics of the beginning of a story. Who's my character? What's going on? What's important to the context of the story? The middle of the story is your conflict. Without a conflict, a story is not a story. I don't care if you call it a conflict, a dilemma, a challenge, a paradox, an issue, a problem, you name it. That needs to become clear. Now, in Robin's story, something very interesting happens, because the initial problem is, what do we do to get funding? But the real conflict is what? The real conflict in her story isn't around how to get funding. It's that she didn't really structure her presentation to do what? To get what she needed. She thought that by sharing with people a lot of nitty-gritty data and telling the story from the perspective of a patient that had passed away, that she would be getting people to empathize with her situation for monies for molecular testing. And what happened instead? What did they get caught up in? Pertussis, right? They went off in a completely different direction because that's the way she had structured her presentation, unknowing to her. So you have to know what that main conflict is. There's going to be a lot of little ones around it, but you got to know the main conflict. And then third, you need to have a resolution to your story. Now, when I first got Robin's story, the resolution was failure. It didn't work. And that's okay, because your key point in your lesson always needs to be positive. Let me give you an example. I lived for a while in Hoboken, New Jersey, and there was a man walking his little boy down the street, and the little boy kept wanting to play in the stones around the trees. And there were trees every couple of feet, and the father kept saying to him, stop playing in the stones, get out of the stones, stop picking up the stones, stop throwing the stones. And he was very exacerbated by the whole situation. Finally, he looked at his son and he said, walk on the sidewalk. And this 2-year-old boy, I kid you not, looked at his father and he said, walk on the sidewalk, walk on the sidewalk, walk on the sidewalk. And he didn't play with the stones again. Your key point has to be about what you want people to do or to say or to act or to behave or to think or to have a different feeling about. And it needs to be positively stated, no more than 7 to 9 words. So people can remember it. And when they remember it, what do they remember? The story, the trigger for what it is that you want them to do differently. So hopefully they will retell that story. Now, the only time I don't include an ending to a story is if I'm working with really, really smart people in a training session, highly educated folks, and then I might give them the beginning of the story, the middle of the story, and say to them, okay, you folks over here, closest to the wall, you're going to give me the optimal ending of the story, just craft it. Those of you in the middle of the room, you're going to give me the worst possible ending to the story, and those of you over here are going to give me the ending that's likely or plausible. And then we'll talk about what the different answers are. You can compare and contrast them and what was done differently in each situation for learning purposes. When you ask people in those settings if they want to know the real ending to the story, they often say no, because our answers are far more interesting than probably what really happened. But 99% of the time, you need to have a resolution. How did the story end? And then attached to that, if we want to influence people to understand the importance of clinical chemistry especially, we need to add the key point, pick and polish the perfect story, and a call to action. What about you? When have you been in situations just like this? How does this apply to you? Because I want you to start thinking about, when could I use this information? All of those are key in structure. Now, what you've also heard me talk about are some of the elements of story, and this is what makes story different than an example. You see, if I had made the story that Robin had given me into an example or a description, it would have sounded something like this. For quite some time, Robin and her boss had been talking about how to get monies for new technologies in the molecular testing session, and one day, her boss said, maybe you ought to go for a building block. So Robin put together a presentation that included a fabricated story about a little girl named Bonnie. And on August 20th, she went in front of the deputy director and the executive director of the health department. And the presentation did not go well for her. And 2 days later, she learned that she wasn't going to get any monies. Now, how interesting is that? Really, how interesting is that? Not much. Very interesting, right? People kind of tune out. That's what most of us are doing in our conversations. We're telling anecdotes or examples or descriptions. They're not stories. And so people have no reason to pay attention. Story, by definition, as I said, has to have conflict, like Robin's story did. It has to have a main character. She was the main character in her story. There were some other people who were in it, too. Those characters need to talk. And they have to have two types of conversation. One is the external conversation with other people, and the second is internal dialogue. So when I went, those other issues are fairly easy to understand, but our work in the lab is more complicated and complex. That's Robin's internal thinking. So you know what's going on inside of her, and you can track along. And it's very interesting. I always say to people, if you want to learn how to do internal dialogue, turn your TV to the soap opera channel, right? Where there's a guy on one side coming towards a door, right? And he's saying to himself, I wonder if she's as beautiful as she was in high school. And I know this is 30 years later, right? And the woman's on the other side of the door, and you hear her saying, no, we would never do this in real life, but she's saying something like, oh, he was my Prince Charming in high school. I wonder why he's coming to see me, and all these other things, right? And you will learn how to write that internal dialogue. The other thing you need to do is to put in sensory information. So I told you what? I told you how hot a day it was, right? 90 degrees Fahrenheit. I told you about what Robin was wearing and that she had a broken foot. So can you imagine what it was like for her to stand up during her whole presentation? She was wearing what color dress? Maroon. Her earrings were silver. They were from Mexico. So you can get visuals in your mind. Or the two gentlemen. I mean, the way I described them, you might have thought of what? TV characters? Because there is a bit of a comparison that she had. I won't use it here with what she labeled them as, not in terms of the way they treated her, but just in terms of their physical appearance. So you want to attach to things that people already know with sensory information. Then we need to have contrast. Contrast is between good and bad, black and white, evil and good. We had the contrast with the two gentlemen in terms of the way they physically looked. We had the contrast with Robin having all of her colleagues and her boss say, hey, you're going to be great, you rock. And then what happens? It didn't. Kind of didn't go well. It didn't go anywhere, right? And she didn't get any monies. So that's a contrast as well. Often when people tell me stories, the contrast isn't in there. You need to add it, and yes, you can do that. There are liberties that you can take in stories with people's permission. There also needs to be drama. The drama was when she gave the presentation, right? All of a sudden it veered off track. They're talking about pertussis. They're not supposed to be talking about pertussis. How do you get them back on track? She gets them back on track, and the next thing you know, they're saying to her, well, this is how you should do your presentation differently. And you're like, what's going on here? That has to be resident in a story as well. And it is in real life. We just have to bring that in to our narrative. Then we need to have layers of meaning. Now, if we were in a setting today where I could ask you what meaning did you get from Robin's story, I can guarantee you there are at least 10 different meanings in this room. Now, why is it important for you to know in advance before ever telling a story what all those layers of meaning are? Because you do not want one of them to offend someone. And if you need to shorten the story from being 8 minutes long to being 3 minutes long, you need to decide which layers of meaning are going away without impacting your key point. Because that key point that you keep, that layer of meaning that you keep, has to be the universal key point. The one that will always stay with that story, that everyone who hears it will resonate with, because they get it. And then attached to that, you will have your call to action. You have a decision to make when you leave here this afternoon. You have to decide if you're going to free your stories from the data. Because if you don't, you might end up in the situation that Robin was in early on. So what's my call to action to you? When you leave here today, I want you to think really long and hard the next time you put together a presentation, the next time you put together an article, the next time you put together a grant proposal, the next time you have to stand in front of someone and influence them to do something on your behalf, whether or not you're going to take the time to pick and polish the perfect story. Thank you. I'd like to introduce, and I understand that almost everyone in this room probably already knows him, Dr. Alan Wu, who is the professor of Lab Medicine at the University of California in San Francisco. Dr. Wu, thank you.
Wow, that was a tough act to follow. I'm not sure I can. So you've learned that the power of telling stories is something that we can use in our day-to-day lives, that we can try. We are always trying to influence people, whether it be our employers or employees or whatever. It could even be a family member, or it could be something that you need to come across. I think that what you've heard today is that storytelling is the most effective way. And so Lori will be available tomorrow at the bookstore. If you're interested in, because I think this is applicable to everything that we do. And you can get a lot more information. She tells me that, that this is just a snippet of how we go about telling stories. There's really much more involved. So today, I'm here to tell you about my story, but it's not about me. It's really about all of you. So as Lori mentioned and others have mentioned, I am you. I've spent my entire career doing clinical laboratory work, whether it be teaching, whether it be doing research, whether it be running a clinical laboratory. Many of you do the same thing. Or in the case of the IVD industry, making products that help us go. We're all in the same boat together. And so what is my message today? What is the theme of this session? The theme of this session is how do we promote the value of what we do to not just ourselves. This is what I'm doing to you now. I don't really need to promote the value of what we do to you because you are me. You are doing what I do. And that's not the point. So the call to action is not to convince you that what we do is important. The call to action is what are you going to do to promote the value of what we do? And what are the tools that we have in order to do that? And the only way that I know is to tell you what I've done. So it is about me today. Most of the time it's not about me. What I have done is what you've just heard. I've written stories. I write stories. I tell stories. Now, I haven't been privy to some of the things that Lori has taught me over the last 6 months of me working with her. So you have the benefit of having this knowledge, and I hope that you take it home. I hope that you do say, I need to tell my story. I need to promote who I am, and in doing so, hopefully you're promoting the person sitting next to you, because this is all going to change. This is going to be a revolution that we either are going to be a part of or we're going to be a victim of. And what is that revolution? So, okay, I promise not to show data. It's difficult for me to do that. I'm a scientist. You are all scientists. So I have to show data. But it won't be much. And it's not scientific data. It's this. This is the U.S. healthcare expenditure as a fraction of the gross domestic product from 1985 when 1965 to the year 2015. It's gone from 5% to 20%. 20% of every dollar that we spend goes on healthcare. And it's not flattening out, it's just continuing, okay? And then this is my only second last data slide, sorry. This is how we compare to other countries. So we have other people from all over the world. This is us. This is from the other parts of the world. And to you, I say, okay, you're doing a better job than we are. Your gross domestic product spending is half of ours. And maybe you have a chance of surviving the next wave. I suspect that the answer is that you won't. So what's going to happen? What is our call to action? If we don't promote ourselves, then we will be the victims. So 70% of all laboratory tests are based on the result of a clinical lab finding. All medical decisions, I should say, based on the result of a clinical laboratory test. But are you confident that when it comes down to budget cuts, that your door is going to be bypassed? Are we sure that when it comes down to fighting with our colleagues about who's going to get funding, is it going to go to infectious disease, as Dr. Ribner is going to be talking about? Is it going to go to obstetrics and gynecology? Is it going to go to surgery? Is it going to go to the clinical laboratory? Who believes in this room that it's going to go to the clinical laboratory? Nobody. And that's because we haven't told our story, because nobody knows our story. So, common gathering at a family outing. Or let's say that you're meeting your future mother-in-law for the first time. What do you do for a living? Oh, I run a clinical laboratory. We do testing of blood for hospitalized patients. Oh, well, that's nice. Big glazed look in your face. Walk away. This is the story that we tell. I mean, you tell me that hasn't happened to you, right? It has happened to all of us, and we are the losers for it. So that's not the story you tell when you're talking to people, and it can be anybody, it could even be your own children. I think that most of the people who have children here, your children don't know what you do, right? Because you haven't told your story. You haven't promoted what you do. More importantly, you haven't promoted why what you do is so damn important. Okay, so in the future, what you need to say is, well, let me tell you about Johnny. Johnny was a 16-year-old boy who came into the hospital. He felt totally fine, and all of a sudden, he had this anemia, and we couldn't figure out what was. So a sample was sent to the lab, and we looked at his white cell count, and this led to this and that. And so now this is a story. So now this is about somebody, a character. Lori talks about a character. Don't talk about data. Oh, yeah, white cell count of 55,000. Okay, again, Glaze is back. We're still back to the same square one. No. What did you do? What was the conflict? The conflict that he had leukemia. What did you do? We helped make that initial diagnosis. What was the outcome? We treated that child. He lived. And it's because of the tests that we do. Why? What was our role? Okay, well, I get this all the time. You take a sample, you put it in a machine, you push a button, and you walk away. All right? We don't need all these people here to run this lab. Okay, again, I'm preaching to the choir here. You all know that we do important things. We have to make sure that the quality is there. We have to make sure that our accuracy, and who do we need to tell that to? Okay? We need to tell that to our customers. So not only do the general public don't understand that what we do, present company accepted here, most of our colleagues don't know what we do, at least in terms of what it takes to generate an important and meaningful product that we can rely on, that we can make pertinent medical decisions on. And literally life and death decisions are being made on the basis of the results that we provide. And at the end of the day, we go home, have dinners with our families and wives, and nobody knows of the heroic things that we have done in our laboratory. And it's not just the value that we provide, but let's think of it from another sense. What is the risks that we have encountered in providing the information that we do? When soldiers come back from the Middle East or from Afghanistan, what do? We glorify them, and rightfully so. They tell their stories. I'm from Boonville, Arkansas, and I have 2 kids at home, and I lost an arm, but that's okay. I was protecting my country. Okay? How many people know about how many hospital-acquired infections of laboratory staff or people who have worked in the lab that got HIV or died, or the risks that we face in treating a patient who might have Ebola, as we'll hear? Does anybody give us credit for that? No. We go about and do our job, and we go home, and yeah, we have personal protective equipment, but nevertheless, it's a story that we don't tell anybody. And partly it's because it's within our DNA not to brag about ourselves. We didn't get into this field because we felt that we were good at self-promotion, or that we could hit a curveball, or that we could spin tales like Lori tells us to spin tales. We do need to do that. We're just not good at it. We have other people who are good at that, and we have names for them. People who spin tales, They're called politicians, actors, lawyers, directors. Okay, so they do a great job at self-promotion. And that's why they're so successful. And that's why we're willing to part with our disposable income so that we can hear their stories. Well, I'm here to say that they should be parting their disposable incomes because they want to support good medical practices. And that's what's worth spending money on. And good medical practices include especially us, the clinical laboratory. So we need to change our tune. We need to start telling our stories to whomever will listen and go about doing it in a meaningful manner. So, again, I told you that I'm going to tell you about what I'm doing, so I'm going to tell you a story of how I got into it. All right, so I was reading a paper, my local Palo Alto News, and there was this ad in the bottom. It says, enter our short story contest, deadline extended. This was 5 years ago. And I go, oh, that usually means they don't have enough entries, and maybe I could write something about the clinical laboratory that might be interesting, a story that I've encountered, and I'll have a chance of winning. So I wrote a story. It was about this nursing home. It's a case where I was involved in a medical legal environment, and the person died, and there was questions about the postmortem analysis. We found high levels of quetiapine, but the pathologist says it's postmortem redistribution. The person died of natural causes. The kid, the daughter, said, no, I just saw him a few hours before he died. He was fine. He was lucid. I don't think it was an overdose. I mean, I think it was not. I think it was an overdose. I don't think it was natural cause. There's something wrong here. So she hired a lawyer. The lawyer hired me, and I looked at the postmortem data. And I said, well, I wasn't at the autopsy. The pathologist is competent. I don't think there's anything here to this story. And then I found out, but, better check the pharmacy records, better see if there's a link between how much he was given and how much we found. And if it was a little bit off, maybe we could have something here. So I looked at the pharmacy record, and it looked normal, usual dosage. And then I said, well, let's look at the nursing record and see, well, how much did they say they gave him that night that he died? And then the nursing home said, well, we lost the nursing notes on the day he died. And I go, what? He says, yeah, they're misplaced. We can't find them. So right away, ears come up. I say, there's something wrong with this picture. So I dug it a little bit deeper, found out that, in fact, the levels not only were that the level of the drug that he was on was high, but the levels of the other drugs that he was on were, in fact, in the normal range. And I said, well, if it's postmortem redistribution, then how come these others aren't high? They should all have leaked out of the blood at the same time. And so armed with that information in open court, I was able to convince the other side to settle. Because I said, hey, you don't really have good evidence here that I think that this is postmortem redistribution. So I wrote that story, submitted it, thinking, okay, I got this, right? I got the drama, got the characters, everything that Lori talks about. I have a resolution. The call to action is, be careful where you put your mother or grandfather. Make sure that it's in a reputable home. It's worth the extra dollars. And I found out later that they had given him an overdose of quetiapine because he was real belligerent, and he was angry, and he was making the other people making noise and disturbing them. And they wanted to quiet him down, and so they gave him a little too much, and he died. And so I picked up the paper, hoping to see my name as the winner of the contest. And I come to find is not only did I not win or take second or third, I wasn't even honorable mention. And I'm going, okay, what am I doing wrong? So I contacted one of the judges, and I said, I thought my story was good. I read the others that did win, and I didn't think they were as good as mine. A little ego there, a little bit of self-promotion. And he goes, actually yours was the best story. We loved it. I'm going, okay, well, what am I missing here? If you loved it, how come you didn't give me the award? Not that I needed the award, but, I want it now. I was curious. And he goes, well, because you were talking about a nursing home, and most of our readers are senior citizens. And it's not the kind of story we want to tell. So then he says, but, you know, I think you should write more of these stories, and you should, and you have a promising career. And so I took that information, and I did write a family of books. They're being sold at the AACC, and it's not directed at this audience. It's directed it's about stories of people who encounter the clinical laboratory, and in some cases, the laboratory solved the problem and was the hero, like in my case I just told you about. Sometimes it was about something that the lab did wrong. Now, Lori says, don't tell bad stories, and to some extent that's true. But at the same time, I want to make it real. I want to say, well, you know, do you know about the heterophile antibodies that produce a false positive HCG, you know, the so-called phantom HCG? Okay, so there were women who had unnecessary hysterectomies and chemotherapies and went into coma. That was on us. This is a story that needs to be told because it tells us where we are fallible as a profession, where we're human. This is why we need to pay attention. This is why we can't just say, well, everything's hunky-dory, that everything we do is great. In fact, it's very important that people know what we do and why we do it. Because if we don't do it, then people can die, and people have. So it's about the good, and it is about the bad. And that's the kind of the stories that I've told. Now, call to action here. What is it that I expect you all to do? Now, what I've done is I now speak at high schools and at Rotary clubs and retirement homes, library clubs, and people do want to hear about the clinical laboratory because they are engaged with healthcare. You know, this isn't some off the beat topic that nobody has interest. Everybody has interest in healthcare. Everybody has somebody who has diabetes or cancer or rheumatologic disease. And I think that people are, in fact, hungry for medical knowledge. And we heard from Dave yesterday that the ACC is supporting this concept of open source lab testing, that you don't need a doctor's office, that we're encouraging people to order testing on themselves. And I think that this is a good thing. I think that we need to be a better consumer of medical information, just like we're a big consumer of food. You know, we don't eat like we did 20 years ago. It used to be whatever you put in front of your face, you ate. That's not true today. We look at labels. You know, what's the trans fat content? What is the is it organic? Does it have genetic modified ingredients? Okay, so we make a big deal about what we put into our bodies, but we don't really do much about what's done to our bodies as a result of a clinical laboratory test, a medical decision that's being made that might be wrong, that may in fact have a major impact on our future livelihood. And we are the people to educate that mass. And people, I think, are hungry, and it's important to begin telling our stories. Okay? One other thing that I want to talk about, and that's if you're going to tell your story, then tell your story about not just who you are, but what you do and what your laboratory does. And this is a concept of branding. So a couple of blocks from here is Coca-Cola, right? Coca-Cola is one of the biggest brands ever, over 100 years, and it continues to be so. They're successful because their brand is better than anybody else's. Well, I'm not saying that we need to compete against each other, but what I'm saying is that we need to brand what we do. If you work in a children's hospital, then you focus on high accuracy on low specimen volumes. If you work in a cancer hospital, you focus on things that are relevant to the treatment of cancer that you won't get anywhere else. If you are a inner city hospital like I am in San Francisco, where we have a lot of infectious diseases and we have a lot of toxicology issues, you brand your laboratory as the toxicology lab at San Francisco General Hospital. Now, I haven't done that myself because it's very difficult for me to do that, to boast and to brag about what we do, but this is what we need to do. We need to get out there. So I have some other examples of other branding. So these are my books. So this was a poster that, an advertisement in Minneapolis that I borrowed from Fred Apple. He shows us a lot. It's a very subtle ad. It says heart attack period or heart attack comma. And if you go to this Park Nicollet Heart Center, you want to be in the area where heart attack is not the final word, period. It's heart attack, here's what we're going to do about it. All right? So this promotes their hospital and promotes the expertise that they have at that heart center. I would venture to say that maybe there could have been another ad. Maybe we should be thinking about how we can brand our laboratory. 90-minute rule out with the investment of high-sensitivity troponin, okay? This is a laboratory test, okay? So we are promoting that maybe we're the first one in Minneapolis that are able to use high-sensitive troponin, and here's why it's important. Branding your laboratory. And then I was at MD Anderson Cancer Center, and one of the world's best cancer centers. And throughout the hospital, there were these different posters about promoting patients. Here's one about this kid, and promoting the staff. Here's another one that I am MD Anderson. This is what I do. This is my story. What we need to do is we are the clinical laboratory. Here's our story. Very subtle. It doesn't cost you anything. You just have a poster. You say, we are real, and these are the things that we do. In fact, we do that. This is a poster. Lab Week, it's a good opportunity to do these kinds of things. 2015, this is who we are. We're actually people, and we have our own stories, and we want to tell our stories, and we want to make sure that you know about them. Okay, I just have a few more minutes because I want to keep us back on schedule. I'm going to show you a video of a story that I tell.
Now to that huge rave at the Cow Palace that sent 11 people to the hospital tonight. 5 of them are still in critical condition, including one who's in a coma. We're also learning more tonight about the young man who died, reportedly from taking tainted drugs. KTVU's Amber Lee live tonight at one hospital that is treating some of those patients. Amber?
Frank, we're at SF General where 23-year-old Anthony Mata died and 2 others remain hospitalized here following Saturday night's rave. Tonight, Anthony's family told us they want those responsible prosecuted.
I used to be a technician at Piercy Turner.
Mata's aunt, Marie Ariano, clutched his high school graduation photo, telling us the family is in shock.
We love him and we miss him. More than anything, they just want him back.
Anthony lived here in Santa Clara.
Okay, so that is a story. That is the beginning. This is a real person. This is a real life that was taken away. What happened? So right there, we have conflict, we have drama, we have dialogue. I'm working on this, Lori. Bear with me. And then where's the message? Where's the end? The message is that we were involved in solving this case. Now, if you heard very carefully, the newscaster said that this unfortunate Anthony Mata died of taking tainted drugs. So he was at this ecstasy party. It's called rave. It's a rave party. And there was a pusher that was given these pills that happened to be tainted. And they thought that there was some chemical compound that was causing his death. Because rave usually isn't that heavily poisonous. So we got contacted in the lab. It was Memorial Day weekend, 2010. And my group had to try to figure out what it was that was in those pills that was causing this person's death. And it was important because there were 9 other kids who were at different Bay Area hospitals fighting for their lives. And it would have been nice to know what it is that they're dealing with. You know, should we do dialysis? Should we do charcoal? Obviously, supportive care would have been key. And we found out, so the end of this story was that, in fact, it wasn't tainted drugs. The drugs were very pure. And we found out that it was at a level that was 3 times the concentration of a typical black market dose. And this was, in fact, an overdose. And it wasn't some other thing that they were chasing, that it was just ecstasy. And we know what to do with ecstasy. And as a result of the decisions that were made from the information that we provided, these other 9 people survived. This is true life. This is how we impact, not maybe always so out there in terms of network news, but we need to promote that, and we need to say this is our story, and this is why our story is so important. Okay? So our next speaker is going to talk to us about, so there are many ways to promote what we do. And what I do is an N=1. I tell my stories, I write my books, and I hope people read them. But I think there's a bigger way of doing this, a more global approach that could get to the end target a little bit faster. And I'm just pleased as pink to hear that these activities are going on in Australia. And it's a model that we need to be doing here. So our next speaker is from Abbott Laboratories, but his passion is promoting the value of pathology and laboratory medicine. It's John Carruthers. Please welcome.
Thanks, Al. Thank you, and thanks for the opportunity to share a story that we've been running now close on 5 years, and it's only really this week that we're going to that next level, which I'll share with you shortly. What are we trying to do? A lot of what you've heard about today. How do we make people appreciate the value of what we do in pathology? So I'll take you on a bit of a journey as to how we've got to where we are at, and we're only part way through what I believe will be a unique story and something that the globe can hopefully learn from. From a disclosure point of view, as Alan's mentioned, I do work for Abbott. I'm also part of IVD Australia, which is a representative body for IVD companies in Australia. And what I'm talking about today is in my role chairing Pathology Awareness Australia. Just setting the scene for those of you who have not been down under. Australia, geographically, a very large country, almost overlays that of the US, but a very small as far as population, with about 23 million people. It is a developed country with a high level of healthcare, and it's an area of high consolidation. So when you look at pathology, it's probably the most consolidated market that exists globally, and one that others can look at and understand where pathology may well go as the future unfolds. A little bit of a story about Australian pathology, and one that can be reflected probably globally in a lot of areas. Back in the far left there, in 1985, there was a separation. At that time, pathology was doing quite well. It was quite a lucrative business for those who were actually doing the private side of the business. But there was a change, a realisation from the government that something had to change in healthcare, and a target at that point in time was pathology. And as you can see, the separation of consumer price index, average weekly earnings, versus pathology up until now has seen a negative decline in rebates for pathology of negative 10.5 versus the other indices which have obviously increased over that period. Shocks are what often causes reactions to occur, or people to actually change their behaviour. And it was in 2009, 2010 when things seemed to come together to enable what we're doing today. At that point in time, and this is from the Health Department of Australia showing what was going on, the expenditure in pathology through what we call the Medicare benefit scheme was around $2 million a year. The average growth of pathology in services was around 5 to 7%. All of a sudden, there was a marked drop, an unexplained marked drop of 2%. And that created a reaction of questions of those providing pathology, trying to understand what was going on. And at the same time, our health minister made an announcement ahead of the May budget in 2011 that they're going to cut $550 million out of the pathology budget to offset what they were seeing as natural disasters that were occurring in Australia at the time and some patchwork economy issues. They're also talking about cutting $400 million out of medical research. What unfolded was a little different And this highlights the impact and the value of making the public aware of your concerns, your issues. At that time, the medical research people in their white gowns got out on the streets and held up banners to highlight the impact of cutting medical research in Australia. Pathology didn't do too much at all because, interestingly enough, pathology, I find globally, sits back and waits for it to happen rather than getting up and doing something about it. So what was the outcome in our May budget? Well, Discoveries Needs Dollars was the campaign My Medical Research, and as a result, the cuts were abandoned. In pathology, $550 million were cut out of the pathology budget. So it's not an unusual story. It's not just in Australia. It's something that we hear globally. Just happened at that time I was fortunate enough to be involved in a strategic model by it's a Blue Ocean model out of INSEAD University in France. And I was fortunate enough to be educated on the strategy behind this. And really what it's about is taking ourselves out of a very red ocean where it is very competitive, a lot of blood in the water, like our friend here, Mick Fanning, an Australian who had a recent encounter which probably most of you would have seen, a situation where full of sharks, blood and so forth in the water, versus moving into something a little bit more pleasurable, a bit more blue water, finding areas in a market that are a bit more lucrative and able to exist a bit more than we do today. So it was this model that I looked at from a healthcare point of view, and I suppose taking one step back, what do we know about pathology? You've heard it today, that most of healthcare does rely on pathology. We hear about the 70% of clinical decisions being made on pathology results. If you're unfortunate enough to have cancer, 100% of it will be involving a pathologist in the diagnosis, and now with the treatment and also monitoring, pathology is front and centre. But realistically, it's invisible. It's the blood taken out of the tube and it disappears into a black box. So the general public and a lot of the clinicians have no real appreciation of what goes on inside your laboratories. And importantly, the government and the other users of pathology perceive it as a cost rather than a value. And that's an issue that we face today and will continue to face. So the model that we employ, or I used at the time looking at the healthcare industry, was a strategy canvas from the Blue Ocean methodology, and I apologise, it doesn't follow Laurie's recommendation, so I'll try to keep it simple. But what it involves is looking at the industry as a whole, and at that time we were spending $815 billion in our healthcare, 9% of GDP, not the 20% here in the US, and pathology spend $3.5 billion, around 3%. 2 to 3% is pretty consistent globally of what pathology costs. And when we compared it to other stakeholders in healthcare, pharmacy, nursing, pathology, other specialties outside of pathology, general practitioners, and plotted them on what we call competitive factors on the x-axis, price through to government perception, and you can choose different factors if you want, and what's the relative value offering. And when we plot pathology, low cost, 3% of healthcare budget, impact on quality of life and clinical outcome, as we've heard, extremely high. As far as career attractiveness, public perception and government perception, you can't get much lower. So that's the issue that was jumped out when we went and did the strategy canvas. And one of the other models is looking at what they call this ERC grid. What are you going to eliminate, raise, reduce and create? And the first thing we needed to do, if we're going to change the awareness of the value of pathology, is remove this competitiveness that goes on in our industry. In Australia, it's highly competitive, highly consolidated, and the privates killing the privates, the companies killing the IVD companies going after one another, the public pathology versus the private pathology. We spend a lot of time going after each other's throat, and we actually forget that we're actually relatively insignificant. We're probably 2 to 3%, as I mentioned before, of healthcare. So if we're going to change awareness, it's something we need to do together. And I'll jump through to create, from a time point of view. We felt we needed to raise awareness of what goes on in this tube, the journey of the tube, what goes on in this black box called pathology. And we also need to do a better job of getting health economic data, because pathology is particularly poor at highlighting the value, quantifying the value of what we do. If you look at our pharmaceutical cousins, they do a great job. They have health economists working for them. Whereas pathology in Australia does not have one health economists coming up with the facts and data of the value of what you do. So if you're talking to government, good luck having a good argument if you haven't got facts and data to back it up. So where do we want to get to if this journey was to go more to a blue ocean? Well, we want a bit more here for what we actually do. These two elements don't change, the impact on healthcare that we have, and we need to be aware of the future people working in our laboratories, because unfortunately it's an ageing situation, and those coming behind are lacking a lot in their skills and capability to continue what you're doing. We need the public to be understanding of what we do. We need to raise that attractiveness, and in turn the government. So we're not expecting to be up here, but we want to raise the bar. So what have we done in Australia? Let me take you into that next stage of where we've come over the last 3 years. Ultimately, it's about the power of one. There's been a lot of individual efforts by different groups trying to do this, and all of them have failed and failed miserably. And that will continue, I believe, until this potential opportunity of working as one to make a difference because of who we are and where we sit in the pecking order. So in Australia, what we've been able to do is get pretty much 100% of all stakeholders, the 25,000 people who work in pathology in Australia, around the table to agree on a campaign to raise the value of pathology. Where you've got the College of Pathologists, public pathology, the privates, the IVD industries are all represented around the table under the umbrella of what we're calling Pathology Awareness Australia. It's a company, it's a not-for-profit, it has a constitution and has governance and follows all those requirements of that of having that type of company. Importantly, it doesn't fit under anyone's umbrella. Because if you were to do that, you automatically splinter. We had to create something that was unique and stood alone. And we needed a brand. It's not Coca-Cola, but we'd like to think it has something that will resonate. And it's no pathology, no healthcare. Why? It actually does mean something. It's true. If you want to know about your healthcare, you need to know pathology. And it's the positive no, it's the KNOW. But we also know if it is NO, then you don't have healthcare. And that's a message we wanted to resonate as well. So with any campaign, there are components. We need to educate the public. We need to help make them aware of what goes on in this black box. We needed to communicate what we were doing through to the politicians. We needed third-party verification, and we needed health economic data. So they're the four elements I'd like to take you through now as to what we've been doing in Australia. Firstly, educating the public. Well, today it's about the website. Having an internet site that people can go to learn about the value of pathology. So we've created it, knowpathology.com.au. In the last 30 days, we've had 6,000 visitors, and you go, well, that's not a big deal. Well, it's a good start, and I'll talk about what we're doing next to take that to a very higher or a more significant number. Importantly, when we have a visit, they spend 90 seconds on the site. And when you look at the average site time for people nowadays in their busy web day, 90 seconds is not too bad. And the most popular part of our website is what is pathology, which is exactly where we wanted people to go. Here's our website, and on our face of our website is someone by the name of Kathy Freeman, probably the Michael Johnson of athletics. In the year 2000, we held the Olympics in Australia, and Kathy Freeman won the 400-metre gold medal. Kathy Freeman is a mother, and she's also a diabetic. And pathology is relevant in her life, and a good spokesperson, a good ambassador for what we're doing. On our website, we have two key areas. Do you want to know about your test? And do you want to know about pathology? And if I click on, do you want to know about your test? We link through to a very important website that most of you should be aware of, Lab Tests Online. We're a sponsor of, we invest in the development and maintenance of Lab Tests Online in Australia. It's a critical site. It's a government-backed, credible site when you want to know about what your test means. So the relationship between Lab Tests Online and Pathology Awareness Australia is fundamental to our ongoing success of the campaign. What are we doing now to reach the masses? Well, in Australia, there's 140,000 approximately people having a blood test every day. So 1 in 2 Australians, 12 million a year, have a pathology test. That's where people care about pathology. When they're confronted with a blood test is when they actually care about pathology. So what we're doing, we're engaging, because we've got everyone working as one, we're rolling out what we're calling a business card model, which is these down the bottom, which provides an opportunity for a person who's having a blood test to go to the website to learn about the tests that they're having. Importantly, it's not disruptive to workflow, and it fits very well with the government as well, which is about an informed patient, which is an initiative that they'd like, which they're pushing. Also, very important are the collectors, the phlebotomists across Australia. We have 5,000 collection centres that take the blood and then transfer to pathology laboratories. They're the face of pathology, and they need to be positive about this initiative. And we've got a really good feedback how easy it is to administer, and they actually see that it adds value to their job and to their patients, their customers, the front up. So what are the next steps? Well, as of this week, we're rolling out 1 million business cards to over 70% of the collection centres across Australia. And that's only happening because we have everyone around the table agreeing to a brand and agreeing to an initiative about the value of pathology. So that's approximately 100,000 people a week who will have the opportunity to engage. Let me take one step back. One thing I missed saying. The testing that we did, the trial that we've done to date, of those that get the business card, 9% actually go to the website. So that's a really important number, and dwell time is 98 seconds. We also know how they get there. 71% desktop, 28% using other more mobile devices, and that's a reflection of the demographics of those having pathology tests. So that's a really important initiative that we've got running to highlight the value of pathology. The second thing, we need to get the politicians involved. So last year in June, we launched Pathology Awareness Australia and the No Pathology campaign. We did it at our White House, the Australian Parliament House. We used Cathy Freeman as our ambassador. And we actually took over the squash court at Parliament House where the politicians go out and bang a squash ball around during lunch. And we set up a collection centre, 2 collection centres and microscopes and different areas to tell the story about pathology. And we bled 50 politicians for haemoglobin A1C to screen as to whether they had diabetes or predisposition. The microscope was extremely popular. Ian Clark here, a doctor who's a histopathologist, spent a lot of time with pathologists looking at prostates and breasts, breast tissue and other tissue as well, explaining in detail what it takes to diagnose those types of situations. We bled the politicians. They had a smile when they started. Often that smile was lost after the needle went into the arm in several cases, but no one fainted, which is a good thing. We had a lot of media coverage. So getting media on pathology is not easy, and it's something we're able to do on the lawns of Parliament House as part of that initiative. And since that time, we've taken politicians through laboratories throughout Australia, and these are examples of them that we've highlighted here. Bottom right-hand corner is our current health minister, who spent 30 days ago spent her first visit to a laboratory and spent 2 hours in understanding what goes on behind in this black box or the engine room of healthcare. And here's in the Sydney Morning Herald talking about cancer and the raising the investment being made, and sure enough, the image that we had was used on the front page of the paper. So in the last 12 months, we've had 20 politicians. These are the head of our government visiting laboratories across our country. Small laboratories, large laboratories, all different sizes and across different parties as well. And they've been really engaging. I've been involved in probably half a dozen of them myself. So that's been a really important initiative that we make them aware of the value of what you do. Third-party verification is also important. So healthcare consumer organisations, I'm sure you've got them here in the US as well. We've got 35 of them who are committed to supporting what we're doing. We don't pay them money. They voluntarily understand the value of pathology, and they voluntarily commit to being advocates of what we do. So Cancer Council of Australia, those types of bodies are very large memberships and really important part of what we do. Here's an example. Ian Fraser If you're into HPV vaccines, probably know Ian Fraser, who was involved in the development of Gardasil and the HPV vaccine. He's a pathologist, by the way. He came to Australian Parliament House along with the CEO of Cancer Council Australia when we did a women's health initiative centred around pathology. So the type of initiatives that we're doing with our HCOs. So what do we do with these people moving forward? We've got joint media, and social media is really important in the initiatives that we're trying to do. Lastly, health economic evidence. And this is an area that we're poorly lacking in, and there are different groups I know globally who are looking at this and trying really hard to come up with the facts and data of the value that we provide. We've got a health economics working group that's together working on putting this together. We've just signed off on working with the Centre of International Economics on a paper on developing this for the Australian value of pathology. So this initiative will give us a key pillar in what we're trying to do in developing the argument and the basis of what we do and the value of what we provide, so we can use that facts and data in the arguments that we have with those that control the purse strings, the politicians and the other bureaucrats in healthcare. So in summary, in reality, it is the beginning of the story. This story may well fail. It may not have a pretty end. We're not there yet. We haven't achieved our 2B. At this stage, healthcare cuts in pathology are still more likely than not. But this week, as I've said, we've created a very important initiative with rolling out to the general public to make them aware of what we do. It's a cost-effective way of doing it, and we believe we can achieve something that is yet to be achieved because of the power of one. So I'm pleased that I've been able to share this with you. Hopefully it stimulates you to at least go to our website, nopathology.com.au. I'd like to leave you with a 3-minute video just highlighting what we've been doing to highlight the value of pathology.
The provision of good health care is fundamentally a team game, and of course pathology is an integral part of that team. So as a general practitioner, it would not be possible to provide good health care without good pathology.
70% of medical decisions are based on pathology. 12 million people had a test in the last 12 months. That's you or someone you love. From capital cities to regional towns and remote communities, pathology underpins Australian healthcare. You may never see them, but over 25,000 people work around the clock to deliver life-saving results.
We could not function on a daily basis without that, the delivery of that quality service. And more broadly, the Australian pathology service is world-class and highly regarded.
100% of cancer diagnosis is made by a pathologist.
When you're diagnosed with cancer, you may see your haematologist, your oncologist or your radiotherapist. You never see the pathologist. And even though pathology is the engine room of the cancer disease or diagnosis.
Early detection of cancer is vital, and the screening programs are about pathologists being able to diagnose in bowel or cancer of the cervix either precancerous conditions or very early cancers that can be cured surgically.
With my diagnosis of ovarian cancer, it actually occurred after I had surgery for removal of a large mass from my abdomen. The pathology really made me aware of it and helped me prevent it getting any worse. When you're in there actually doing the surgery, it's good to know that the pathology can come back so quickly so they can make those quick decisions that could be life-changing.
Pathology is where innovations from medical research and technology are applied. Pathology is central to the management of chronic disease, including diabetes.
I, like most Australians, I rely heavily on Australian pathology. I feel so happy to know that, when I do go and get my blood taken, trying to better manage my type 2 diabetes, that, my blood is in safe hands, and essentially my future and my health is in safe hands.
It's comforting to me as a general practitioner, and it should be comforting, of course, to our patients, to know that the standard of pathology is so high in this country.
Thank you, John. It was great and very inspiring, and all speakers have been doing a great job, so we are well on schedule now, so we will have time at the end if you have questions or comments. So we're talking about stories, and a story broke about a year ago, and we're going to hear about that story now. I'm pleased and privileged to introduce Dr. Bruce Ribner. He is a professor of medicine at Emory University, and he's the director of the Serious Communicable Disease Unit at Emory University Hospital. Dr. Ribner.
Okay, what do we got to do? Do that? I can do this. Okay. Thank you, sir. Good afternoon, everybody, and thank you for inviting me here today. Thank you, Mr. President, for inviting me to your symposium. So my goal today is to give you an outsider's perspective as to the importance of the laboratory in what we do, namely running a unit to care for patients with serious communicable pathogens. And I have nothing to disclose. There's not much money to be made in infectious disease. So it may seem like forever, but it's only been, actually, in 3 days, it will be a year, that on July 30th of last summer, I was sitting innocently in my office, probably filling out some report or other to justify infectious disease, when I received a telephone call from the medical director of Phoenix Air, which some of you may recognize as the only air ambulance service in the world, private air ambulance in the world, which is certified to transport patients with serious communicable diseases. And Michael said, "Bruce, has anyone told you that our air ambulance is about to be taking off for Monrovia?" And I said, "No." And he said, "Well, you probably ought to know that we've just been contracted by a non-government organization, and we're going to be going to Monrovia in Liberia, and we're going to be picking up an American physician who has Ebola virus disease, and we're going to be bringing them back to the United States. And, oh, by the way, we're bringing them to your unit." So I said, "Thanks for telling me, Michael." Well, needless to say, that has led to a very interesting journey for us, for the American healthcare system, and for the American public. Ultimately, as many of you know, our unit cared for 4 patients who were infected with the Ebola virus. And we were also involved in the repatriation of 3 patients who were working in Ebola treatment units in West Africa, who had high-risk exposures and were brought back to our unit to have interventions done in hopes of preventing them from acquiring Ebola virus disease. Of note, all 7 of these individuals walked out of our hospital. So what I propose to do during my part of this symposium is, number 1, just briefly review for you the natural history of Ebola virus disease. Number 2, point out what we think are the keys to the successful management of patients with Ebola virus disease. And then finally, point out to you laboratorians how important your colleagues at Emory University Hospital were in our success in treating these 7 patients. I would hasten to say that I am not going to get very granular about any of these aspects, because we have an excellent symposium which will be given tomorrow afternoon at this meeting, where in fact members from the infectious disease group and the laboratory group at Emory University Hospital will be going into much greater detail into the workings of our unit. So just briefly, reviewing the pathogenesis of Ebola virus disease. The Ebola virus is a filovirus. It shares that family with Marburg virus, which causes a very similar illness. There are 5 species of Ebola virus, which, like all good viruses, are named for the geographic area that they were first identified. The Ebola virus is transmitted primarily by contaminated body fluids, and historically the mortality rate associated with disease has been anywhere from 40 to 88%. In terms of the clinical illness, after an incubation period of 2 to 21 days, most typically 8 to 10 days, the patient has the onset of fever, malaise, headache, myalgias. In settings where laboratory tests are available, there is leukopenia and thrombocytopenia. In other words, patients during the first few days of Ebola virus disease look like anyone else with any other infectious disease in West Africa or, frankly, in the United States. During the 3rd and 4th day, patients enter a phase which is sometimes called the wet phase, characterized by nausea, vomiting, and diarrhea. And as you will hear tomorrow, because of our infrastructure, which is lacking in parts of the world where this disease is endemic, we have made some interesting observations which actually our colleagues in West Africa didn't really appreciate. For example, everybody in West Africa knew that if you had Ebola virus disease, you had diarrhea, nausea, and vomiting. But when we called our colleagues in West Africa and we said, you know, our patients are having 10 to 12 liters of output every day, even they were amazed because, frankly, you know, they change diapers in those units. They don't have bowel management systems. And so it helped them to understand to a large extent why they could never keep up with the fluid losses of these patients. Now, because these patients are putting out enormous amounts of body fluid, and also because the patients have a vasculitis and they also have a hepatitis, which leads to low output of proteins by the liver and therefore low oncotic pressure, we have this very paradoxical situation where the patients are third spacing like crazy. Our average patient puts on 5 to 15 kilos of weight during their 2nd week of illness, and yet at the same time they are intravascularly depleted. They all have dramatic electrolyte abnormalities, hypokalemia, hypomagnesemia, hypocalcemia. They all have a metabolic acidosis, which is multifactorial, and they all have elevated liver enzymes. Now, during the period of time, which starts roughly in days 9 through 12, these patients go into multi-organ failure with pulmonary failure, renal failure, and encephalopathy. So if we for a moment could characterize the difference between patients being taken care of in resource-poor settings with patients being cared for in resource-rich settings, in a resource-poor setting, there is a high mortality rate, as I've said, on the order of 40 to 88%. Totally inadequate fluid and electrolyte support. On a good day, in most of these units, they can replace 1 to 2 liters of fluid a day. And it doesn't take higher mathematics to realize that when your patient is putting out 10 to 12 liters a day and you're replacing 1 to 2, it doesn't take long to go into hypovolemic shock with progressive organ failure, bleeding, hemorrhage, and high mortality rate. Now, in contrast, we who are fortunate enough to work in resource-rich environments are able to keep up with the fluid losses, are able to keep up with the electrolyte losses. A subset of our patients do go on to multi-organ failure, but our mortality rates are dramatically less. And even though I don't know that anybody's come up with a technical figure yet, just my own ballpark figure, we've had roughly 26 to 27 patients repatriated to either the United States or to Europe. And our mortality rate in these centers is running somewhere around 10 to 15%. Along the way, we have seen a dramatic shift in the way we think about the management of patients with Ebola virus disease. If you had looked at any article, any textbook on Ebola virus disease up until last July, the general dogma was that if somebody went into respiratory failure or they went into renal failure, there wasn't much point in putting them on a ventilator or doing dialysis because they were going to die. That was 100% fatal. Well, we have clearly seen over the last year that that's not the case. We have had patients on ventilators, on dialysis, who have walked out of the hospital. And so now we definitely do aggressive intensive care. We also have algorithms in place to do surgery on patients with Ebola virus disease. And in our Midtown facility, we actually have protocols in place to manage labor and delivery in patients who are infected with the Ebola virus. So, what's the key to the management of patients with Ebola virus disease? Nothing very dramatic, just good, aggressive, critical care medicine like any other patient whom we have managed with sepsis. Lung protective ventilation, early empiric antibiotic therapy, electrolyte replacement guided by good measurements, good replacement of fluid so that we manage to keep up with the losses, but at the same time, don't overshoot because we can put patients into respiratory failure when we do overshoot, and aggressive and early support. The other thing that we keep reminding centers as we go out and train individuals who are setting up the Ebola treatment and assessment centers around the United States is that somebody coming back from an endemic area, Sierra Leone, Guinea, Liberia, who comes in with an acute infectious presentation is far more likely to have an infectious disease other than Ebola virus infection. As a matter of fact, roughly half of the patients who come in with Ebola virus disease also have malaria, primarily because of that part of the world, falciparum malaria. And falciparum malaria will kill you just as quickly, if not more quickly, than Ebola virus does. And so every one of our patients, as part of our routine algorithm, gets rapid testing for malaria, and we complete their prophylaxis. There's been a lot in the media and in the medical literature about experimental agents, and with the exception of one or two patients, almost every patient repatriated to the resource-rich in countries has received multiple experimental interventions, whether it's convalescent serum, whether it's chimeric antibody, whether it's antivirals, whether it's vaccine. But I'll stick with the statement I made a couple of moments ago. As of today, none of these measures have been shown to offer any benefit. And you may have, in fact, seen that over the last couple of months, as two of these agents have been subjected to randomized controlled trials, they have been shown to be of no benefit, and the trials have been discontinued. So how have we depended, how have we and our patients depended on the laboratory for our success with management of patients with Ebola virus disease? Again, many of you may have seen this graphic diagram of our unit. We basically have a 2-bedded intensive care unit. We have established a point-of-care laboratory, which is just outside the unit, which again, our group will go into much greater detail tomorrow afternoon. This is just a picture of the instrumentation that we have in the unit laboratory. As I mentioned, all of our patients had marked electrolyte abnormalities and nutritional deficiencies. They had hypokalemia, hypocalcemia, hyponatremia. They required intravenous and, when possible, oral replacement. All of them required massive amounts of potassium replacement. And laboratory testing to measure and monitor electrolytes in our patients was critical, especially those patients who we were managing with hemodialysis. This is just to list that we had chemistry, blood gas, urine analysis, coags, hematology, and malaria, and instrumentation that many of you are familiar with called the BioFire film array system, which has both a biothreat test kit that we could measure Ebola virus PCRs on, a blood culture panel, and a GI panel. Now, as I've said, patients who are critically ill with Ebola virus disease will have secondary infections. When these patients became septic, it became extremely challenging to try and use the routine microbiology laboratory for isolation and identification of organisms causing bacteremia. But fortunately, as you'll hear tomorrow, we did have the blood culture identification system so that we did not have to bring specimens out of the unit and into our standard micro laboratory. Not too many people talk about this other piece of the puzzle, which is the patient under investigation. And these are patients who come back to us from parts of the world where Ebola is endemic. They present with a febrile disease. And again, as I've shown you, during the early part, it is challenging to separate out the patient who may have Ebola virus disease from the patient who may have typhoid fever or the patient who may have malaria, although we recognize that these two latter possibilities are much more common than Ebola virus disease. And so, as we were confronted with these patients who had rather nonspecific physical findings, it was very comforting to have a laboratory which in roughly 60 to 90 minutes could tell us whether or not our patient was viremic with the Ebola virus. Now, many of you may know that during the early phases of disease, patients with Ebola virus disease may not be viremic. But the fact that we had a negative assay at least assured us that the patient was not viremic, and therefore we could do a lot of the testing to rule out typhoid fever, to rule out malaria, which, as I've said, is far more common in someone coming back from West Africa with a febrile disease. In addition, because of our unique geography, while we were ruling out Ebola virus viremia, we were also able to do a lot of the routine testing so that we could immediately identify somebody with falciparum malaria or potentially typhoid fever. Now, as I've mentioned, a key ingredient in the management of patients in resource-rich environments has been the use of experimental agents. Most of these protocols, if they're to be interpreted with any sort of meaning, really require a great deal of laboratory support in terms of viral testing, in terms of acquiring blood samples to do levels of the various agents we were giving the patients, but also in the safety testing, looking for organ damage because of these agents. Once again, we could not have done these studies without a laboratory right there to support us. So what was the role of the laboratory in successful management of our patients with Ebola virus disease? Number one, monitoring of electrolytes, especially in patients on dialysis. Number two, monitoring coagulation parameters. Number three, perhaps one of the most important parameters, ruling out other rapidly fatal infectious diseases such as malaria and typhoid fever. Number four, being able to rapidly evaluate whether somebody had Ebola virus, but equally importantly, ruling out or ruling in whether they had Ebola virus viremia. We also used our instrumentation to follow the course of the viremia in the patients who did have Ebola virus disease, because one of the first things we would see, even before the clinical improvement in the patient, was the beginning of a drop in the viral load. Similarly, we measured antibodies to the Ebola virus, which would appear shortly before clinical improvement started. And finally, managing the experimental protocols to which most of our patients were enrolled. These slides are to impress on you that the management of patients with Ebola virus disease is really an institutional endeavor. And while it's the physicians and nurses who got most of the media attention, we don't believe for a second we could have accomplished the success with our patients that we did without the support of groups such as our laboratory, such as our administration, and again, a number of federal partners from the CDC, the Food and Drug Administration. But ultimately, this is why you and I are in the business. We had 4 patients who came into our unit critically ill with Ebola virus disease. Every one of them walked out of the hospital to return to their families and their community. For those of you who are interested, the Emory website has all of our policies and protocols, including all of our laboratory policies and protocols, which are open access to anyone in the world who is interested. And again, there is a session tomorrow afternoon at 2:30 where much greater detail will be devoted to the laboratory in our unit. And thank you again for inviting me to your meeting today.
That was excellent, and thank you. It's so encouraging to hear a story from our physician colleagues. I think we need to do more of that in the future here at our meeting. It's good to hear from colleagues. We have plenty of time for questions, and I'm going to take the chair's prerogative to ask the first one, and so I wanted Dr. Ribner to stay up here. We obviously can't transport all of the patients that succumb to this disease to America, to Emory, for this excellent treatment. What would you suggest that the laboratory community needs to do to make it possible to do what you did here in Atlanta, in Liberia and other places?
Oh, well, those are 2 very different questions. Clearly, in terms of the United States, I don't need to tell anyone in this room that much like your part of our industry has been under-recognized, emergency preparedness for infectious disease in general in the United States has been poorly funded. I can tell you that we have a unit that's been open for now 14 years. And I wish I were a better storyteller, Lori, because every year it was a challenge to get funding. And every year I was told, well, you know, we haven't really used your unit very much. We had one patient who came back with SARS in 2004, and one patient who came back who we thought had Marburg virus infection. And the years went on, and everybody said, we've got a lot of other uses for your money, for our money. So we're not sure we want to fund you. And in fact, our funding the year before everything broke loose, which is last year, our funding was roughly 1/3 of what it had been, say, 5 or 6 years before. Fortunately, for the moment, I think our government has gotten the message. We have been asked by the Department of Health and Human Services to help put together a national program, which most of you hopefully are aware of. It's a 3-tiered program. Tier number 1 is that every healthcare facility in the United States needs to be able to identify somebody who might have a serious communicable disease such as Ebola virus, such as MERS, and isolate that person immediately. The second tier are what we call assessment hospitals. These are facilities where patients can be transferred, where the rapid diagnosis of either Ebola virus or MERS or some other infectious disease can be made, or conversely, they can establish, this person just has malaria, just has typhoid fever, and manage them appropriately. But then at the top of the tier, if you will, are roughly 70 institutions which are scattered around the United States. We have 5 in Georgia, but there are at least 1 Ebola treatment unit in each of the other 50 states. And these are facilities which are able to care for somebody who has a serious communicable pathogen. And clearly, at every step in that chain, there is going to be heavy dependence on you folks, because I don't think I can say it enough. I couldn't do my job. I couldn't distinguish typhoid fever from malaria from Ebola if I didn't have a superb laboratory backing me up, or perhaps leading me in certain circumstances. Now, David asks about Africa, and there the challenges are obviously much greater. I think the basic thing that the laboratory industry has to do is develop equipment which works in an environment which has 95% degrees, 95% humidity, and brownouts most of the day. And speaking to my colleagues who practice in West Africa, who I believe are just as good at being physicians as I am, they really have been hamstrung by the total lack of infrastructure and the sensitivity of the instrumentation that we take for granted, and its inability to function for more than a few weeks in the kind of setting where 27,000 people have now been infected with Ebola virus over the last year.
All right, thanks. And now let's continue. Does anybody have any other questions? We have a mic right in the middle behind the video camera. So questions, comments for any of the speakers here this afternoon? Please.
Hi, I'm Andrew Bryan from the University of Washington. One of my main question is, for those institutions, including ours, that don't have such an isolation facility, what in your mind are the minimum set of tests that you think are necessary for the treatment? Obviously the chemistries and the malaria testing. A couple of things like the LFTs, we've raised the question, even though that's clearly part of the disease process, as well as the infection agents that have empiric therapies available. Thank you.
And again, I'll sort of answer your question, but I don't want to get too granular because, again, we have an excellent session planned for you guys tomorrow. But basically, the instrumentation that I listed on the 2 slides that, frankly, I went through rather quickly are what we considered, what our laboratory helped us to establish as sort of the bare minimum. You have to be able to do chemistries, you have to be able to do hematologies, you have to have rapid malaria testing, you have to have some mechanism in place to diagnose typhoid fever, which again can be rapidly lethal in these patients. The other reason that we got the BioFire, you have patients putting out 10 to 12 liters of effluent a day. And obviously, coming from the parts of the world where they do, you need to really worry about other enteric pathogens. And the nice thing about, and again, this sounds like a testimonial or something, but I guarantee everyone in this room I have no fiduciary connections at all with this company. But the ability to do the GI panel in 1 hour was phenomenally useful in helping us manage these patients and say, oh, you know what, you've also got, salmonellosis, or you've got this, or conversely, no, we have no enteric pathogens in you. This is just Ebola enteritis.
Okay, more questions, comments for any of our speakers? All right, thank you all very much. I'd like to thank all of our speakers today. Lori, remember, we'll be signing books tomorrow from 1 until 2 at the ACC bookstore. Alan has written his own books, and he's available, I believe, here this week to sign some of those books. And I'd like to thank John also for coming from Australia and being with us here today, and to Dr. Ribner for joining us today. It's been a pleasure to host this symposium, and I thank you very much for your attendance.